Dr. Mike Siatkowski is coming up. A lot of you already know him from last night, but I'll just reintroduce him. He sees children at the eye clinic at OU Children's Hospital. He also sees kids and adults at Dean McGee Eye Institute, where he's also our chairman and CEO at the Department of Ophthalmology. He also is the residency program director, and he recently was awarded the very coveted Stratzma Award for Excellence in Resident Education. And so congratulations again. Mike is also a past president of our society. So he's going to talk with us a little bit about potential pitfalls in pediatric neuro-ophthalmology. Thank you.
So I'm going to talk about a few cases in pediatric neuro-ophthalmology, and there are things actually that you hate to when these walk in the door, but we face these all the time. And then I'm going to conclude by talking about a review of a paper that Brad Ferris and I and one of our fellows did a long time ago. So people get scared of kids, but they're actually a lot easier to deal with than adults, and kids respond to their expectations, and so if you expect them to cooperate during the exam and you tell them that you can do it, and you let them know you're the boss, you'd be surprised at how frequently they rise to the expectation. It's too bad that we lose that trait in adulthood sometimes. So again, I have no disclosures that are relevant to this talk. So this is a great quote from Oscar Wilde, although he certainly had his pitfalls, but this is true. Experience is the name we give our mistakes. So here's the first case. I call it a voice from the past, and you'll see why this is. A 7-year-old girl, decreased vision in each eye. She's been to see 4 doctors already. And so here's what we get. 2100, 2200 at distance. He's definitely better at near. Pinholing at distance, 2050 and 2040, and with a -1/4 sphere, 2040 and 2030. So what are you thinking about at this point? Well, if you're like me, what's going through your head is this is pretty functional, because how do you go with -1/4 sphere from 2200 to 2030? The math doesn't add up. And she doesn't have a significant refractive error. Pupils are normal. Color vision was a bit down, but she missed the test plate, so it's hard to interpret. And I thought the fundus was normal. I looked at it, all the MRIs and CTs that have been done before, and I thought they were normal too. So here is a Humphrey field that we got here, and you look at that. So how do you interpret that? And I think something that always people jump to is the grayscale. And if you look at the grayscale, you may think, oh my gosh, this is actually a little partial superior quadrant tanopia. But really what you should be looking at is down here, the pattern deviation. You see when these are matched with age-matched controls with this level of visual acuity and the same foveal threshold. And it really does not look at all like a quadrant tanopic defect there. So actually, it's something. This is kind of scattered central depression. Maybe it's more defined central depression. So you shouldn't look at the grayscale, because you'll be confused into thinking it's retrochiasmal. Okay, so what is the next step? We have a bunch of scans. Should we do another one? Is it time for an OCT or a VEP or ERG? Could it be hereditary? Should look at the parents, or do we give the functional talk? Well, again, you could make a case for all of those, but I was struck by the 2200 to 2030 with -1/4 sphere. So what I decided to do was give the functional talk, and and we did uncover some areas of stress at school and in the family. And I said, well, let's see how things are going. They were from another state. And I said, why don't you call me in a month? And she did, and she said, well, things are going much better. Okay, so I thought, that's great. Now, 2 years later, she's seen in her local city by a retina specialist, and now visual acuity is 20/70, so it's better than it was 2 years prior, but it's still obviously down. And the color plates are worse than they were at that point. And this is what the fundus looks like there. What do y'all think of that? So, I mean, if you look carefully, you see that, the nerve looks pretty good. It's a little overexposed on the left, but there's a good foveal sheen, but something right in the center may not look quite as right. So we did a fluorescein, and what you can see here is there's certainly some areas of RPE defect, but what strikes you is that in a very late phase fluorescein angiography, there is significant poor filling of the choroid. There's a dark choroid, rather, a hypofluorescent choroid. So, and this is Stargardt's. Now, I want you to look at this letter that I got back. Now, the worst part of this was the retina surgeon was a former resident who, and I used to always tell him, it was a good resident. I almost said his name there. I said, you're really good, but if you could just pay attention to detail a little more, you could be great. And so he did, and he got me on this. So I keep this letter to keep me being humble. And so you have to eat a piece of humble pie. Okay. All right. So what do we learn from this case? Well, first of all, 7-year-olds, unless they're developmentally delayed, should see 20/20. So you can't accept 20/30 from a 7-year-old. That's not normal. Macular dystrophies are a very common cause of occult visual loss in the first and second decade of life, and often go undiagnosed. In Stargardt's in particular, which is the most common one, the acuity may decline a long time before you see fundus changes appear. I've seen a year or two before that. We got a fluorescein then, but nowadays you can use autofluorescence, you could use a multifocal ERG, and you can do genetic testing straight away to get the diagnosis. And in fact, in my practice today, I'd probably get an autofluorescence and then a gene test now, which is how I would proceed, and most insurance will cover that. And the final thing is that this concept of functional overlay is really, really common. So obviously this kid had Stargardt's at the first time when I saw her, but it wasn't a 2200 Stargardt at that point. It really probably was a 2030, 2040 Stargardt. But because she knew something was wrong, she'd seen 4 doctors, she was getting worked up, and there were some issues at home at school, there was this anxiety component on top of it, which is functional overlay. So it means we have organic disease, but on top of it, there's non-physiologic disease, which is further decreasing visual function. And it is really, really common. I would say functional overlay is not just in ophthalmology, it's in all of medicine. Okay, so I like this quote. You know who A.A. Milne was? The author of Winnie the Pooh. And I think, to the uneducated, an A is just 3 sticks. And sometimes we think about these neuro-ophthalmology cases like that, it's so confusing. But all you got to do is just take the pieces apart, and you realize I can actually put this together to make something really simple. And that's what happened in the last case. We just sometimes don't think like that. So this next one I call Fun at the Beach, and there was a 16-year-old girl who was taken to Hawaii on vacation by her family. And, to make a long story short, when the parents were doing something else, she decided to stay at the beach. And the parents came back early and found her in a compromising situation with a boy she had met at the pool. So there was a large family fight that ensued, and the quote was made by one of the parents that you are out of the will. And this was actually a fairly well-to-do family. So there's, this is drama, okay? Okay, so thank God my life is boring compared to that so far. And so she's 20/20 and count fingers at 5 feet. Now, I happen to know the ophthalmologist that saw her in Honolulu, who is very, very good. He said the pupils were normal. He did do a field. He said the fundus is normal. So several people looked at it. They thought, well, there's no RIPD. She could be functional because of the stress, but it could be retrobulbar optic neuritis. Maybe we missed it or whatever. So they decided to treat her with IV solumedrol, and MRI was normal. ANA they got for some reason had low positivity. And then she got to 2200, and she said, I think I'm getting better. Came back home, and a week later, the fellow eye dropped. And so she was 2400 and 2250, but pinholed to 2080 and 2100. Pupils were reactive without RAPD, but of course she has, bilateral visual loss supposedly at this point. And the fundus was felt to be normal. Here's the field, and what you see here, this is, basically a large central defect in both eyes. It's somewhat asymmetric. So clearly, assuming the field is correct, this is bilateral anterior disease. So the scan was normal, the lumbar puncture was normal, Lyme titers negative. Repeat ANA was now 1 to 360 positive, but the anti-double-stranded DNA was negative. Other tests was negative. And so I thought, well, maybe she has vasculitis. Maybe there's some functional overlay here again to whatever's going on. So they gave her some more steroids, had a rheumatology evaluation, repeat ANA number 3, which was totally negative. It was 0 at that point. And the patient said she was getting worse and worse. So then I saw her at 4/200 and 2/600, no collar plates, and this is a number of 6 weeks later. So you can see there's obviously some temporal pallor to the disc, and if you look here, there's a good nerve fiber layer, and it's really dropped out in the papillomacular bundle there, with similar in the fellow eye. So obviously, it's not purely functional at this point, because there's definitely something going on in the fundus. So what do you do next? Do we get another scan? Is it time for NMO titers? Look at her spine. Nowadays, maybe anti-MOG. Vitamins? Vasculitis? Whatever. What should we do? Anybody want to take a stab? What you would do? Yeah, probably send it to a pediatric neuro-ophthalmologist. So this is what we did. We did Labor's testing, and she was positive at the 144A4 mutation. Fortunately, this is actually one of the mutations that has a higher risk of spontaneous improvement in the future. And she did get back to 20/20 and 2200 later on. If you look at this, this is, believe it or not, that this eye sees 20/20. If you see the foveal threshold there, it's like 34. So it's a little tiny window that opens up centrally that allows them to see better. And of course, that's the bad eye. So what do we learn here? Well, Labor's, although you think of it in boys, it can occur in females, and up to 10% of Labor's occurs in females. And it's estimated that 10% of females with the mutation will have phenotypic expression of that. And up to 10% occur in the first 2 decades of life. So you think of it as a young man in their 20s or 30s, but it certainly can occur earlier than that. This is an unusual optic neuropathy in that it often does not produce an RAPD when this one eye is affected. And it's unclear whether there's subclinical bilateral involvement or whether it's just initially only affecting or only sparing the pupillomotor fibers. So we don't really know for sure all the reasons why, but it's well documented. And finally, I had to put in a quote by Lawton here. One of the things he loved to say is ANA is the world's most useless test, and because it's quite variable and it doesn't really help you make a diagnosis or follow disease. Okay, and again, remember there are these 2 mutations out of the 5 most common mitochondrial mutations have a chance of spontaneous improvement in acuity. The field doesn't respond to normal; it's just a window you get through the big central scotoma. And again, like in the first case, functional visual loss, functional overlay is really common because obviously, the math has to add up, and it didn't there. So there was an organic disease on top of non-physiologic disease as well. And Labor's is often really misdiagnosed initially as retrobulbar optic neuritis. Okay, read that quote, see if you like that. So I'm sure we can think of people in both categories who fit the bill. So, all right, another case. I call this one, who knows who Paul Harvey was? If you're old like me, yeah. So, and Paul Harvey used to say what at the end? Here's the rest. Okay, so you'll hear the rest of the story here. So, a 17-year-old football player, he has a helmet-to-helmet impact on the field, and somehow the helmet flew off, and then he's hit again in the right forehead. Bare forehead with the helmet, and immediately said that the vision decreased in his right eye. And he saw his local optometrist and said, well, there's some sort of field defect here, referred to the hospital. They got an emergency CT, which was negative, and admitted him to neurology. So interestingly enough, the past history, last year during football season, he had a back injury, and he had a right hemiparesis, arm and leg. Don't know if face was involved or not. It lasted for 24 hours and spontaneously improved. And nobody ever figured out what happened there. So his 20/20 J1+, the pupils were normal. Anterior and posterior segment exam was normal. So here's the confrontation field at the bedside, and you can see in the right eye there's a very dense temporal defect, says it can't see anything till it gets to the midline, and the left eye was full. So what is the next best step? So another scan, MR, lumbar puncture. Well, I thought, okay, well, something's not adding up here. We need to do a visual field. And so we did a visual field there and say, well, it pretty much looks like the same confrontation field that we got. A couple of things to point out, though. If you look at the right eye, you see that it does cross the midline. So the parameters are pretty good, and there is something both on the grayscale as well as on the pattern deviation that's going into the nasal portion of the field. And if you look at the left eye, it's pretty non-specific. You probably say, I can't really make anything of that. So now what? What can we do? There is a test that will make the diagnosis here. All right, and I was fairly sure it would be a binocular visual field because I thought this has to be functional. You can't lose half of your field and not have an RAPD. So I did a binocular field. This is simply a 24-2 with both eyes open, and that's why there's no blind spot on here. And I was expecting to see a dense temporal field defect there, but there wasn't. So I thought, okay, maybe there is something that's going on that I've never heard of before. So we decided to repeat the field again, just with the right eye. Of course, here we see spiraling of eye softwares, which is really physiologically impossible. Remember, when you look at a Goldman, you're just looking, the field of vision is a 3D thing with the peak at the fovea, and you're just doing slices across the field of vision like this to look at it, and so you can't have a crossing of the eye software, because that would mean that the sensitivity of those spots on the retina kept changing at different times. And then we did a binocular Goldman field, and you can see that although there's not a complete right-sided defect, there is a right-sided defect, and just the nasal portion of your left eye should extend at least to 50-55 degrees over to the right. So this, whatever this is, 20 degrees there or whatever, is not physiologic. That's not possible. So, and of course the neurology said, oh, you missed something. They got an MRI, which was of course normal. So in 1 month he came back. Here's the rest of the story. He said he is 2020, he said his visual field improved, and here's his repeat test in 1 month. So here's the rest of the story. This is a kid who makes me look like an athlete, okay? His father really wanted him to play football. It was forcing him to play football, and he did not want to play football. He wanted to go to art school, and I think that what was going on, this event as well as a temporary hemiparesis he had the prior year, were attempts to get out of this being forced to be a football player. And so it was good to get this out because they actually had a good discussion. I keep in touch with him. He did go to art school, and he's got he's working on a studio and something. So this was a nice outcome for the rest of the story. So some pearls here. Most of the time functional visual loss affects acuity alone, or at least acuity and field together, but there are some times when it affects the field only with the normal visual acuity, so don't forget about that. In a comprehensive ophthalmology practice, 1% to 2% of what you see is functional, so you're all going to see it for sure, but in an academic neuro-ophthalmology, it's about 12%, which is really shocking. What about the fields in functional visual loss? As a confrontation field, you'll see a tunnel field that doesn't expand as you go farther away. We've seen on a Goldman you can have spiraling or a crossing of eye softwares. On a Humphrey field, it's just often all black, but it can also be reproducible defects. There was a study done asking high school and college students to reproduce quadrantic defects, hemianopias, altitudinal defects, and they could do so very easily, repeatedly, after they got the feel of how the thing worked. But remember the usefulness of binocular visual field. You may have to do Humphrey and Goldman in order to find a problem there, and it's another vote in favor of keeping Goldman perimetry around. And so this was a study I was telling you about that Brad and I did with Sue Ann Lim, who was one of our fellows from Singapore, and I think it's still the largest study of functional visual loss in the literature. 38% were in the second decade. very small amount, under 15%, had any psychiatric history, although 30% reported some depression or anxiety. Out of 140 cases, we did find 3 misdiagnoses, which are important: cone dystrophy, Stargardt disease, and Labor. So these are really high on the list, and probably small occipital infarcts would be number 4 on the list. One of the children in this study turned out to be a victim of sexual abuse. And it came out as functional visual loss. And if you look at, here's at the time a meta-analysis of everything in the literature, predominantly female. Half of them had some trigger, and for an adult it's often surgery or an injury or a car accident or something like that. For children it's typically things like trouble at school, trouble at home, divorce, death, stuff like that. And 2% overall were misdiagnosed, and you can see those what the common things were as we discussed. So just a few words to finish up about the ethics of explaining functional visual loss. So the first thing important, is this functional visual loss purely, or is it functional visual overlay with an organic disease? It's really important to separate the two. And you always have to be asking yourself, am I missing something? Am I missing? And the things you miss are typically cone dystrophy, Stargardt, Leber's, and small occipital infarcts. So know the audience. Again, triggers occur in about half the time. Psychiatric disease, much more common in adults, but still a minority. Female predominance regardless of age. Look at the recovery there. It's much, much better in children than in adults. And by recovery, I mean they've gotten back to 20/20 in a full field that you can prove. Again, these are things we have to ask for. Problems at school, social things, bullying, divorce, death. New siblings is one I've encountered quite a bit. Friends have glasses, or somebody in the family. I've seen somebody in the family has MS or optic neuritis. That's been a common one I've seen. And I think we've talked a lot about conversion versus malingering, but let's face it, we're not psychiatrists, we're not counselors or social workers, so our job is not necessarily to distinguish those, but just to say it's functional and help them get on the path to find somebody else who can work through those. Remember, in kids that sexual abuse can occur, and it can come out in functional loss. How do you manage it? This is stuff that's been in the literature. IV amobarbital, I thought that was great, to give the kids truth serum and say, can you see this? Can you see this? I thought how much Dr. Ferris would have enjoyed doing that. Sensory isolation, you're going to patch them for a while and see if it comes back. ECT was actually used for functional visual loss in the past. Placebo drops and glasses, I saw that used as a resident. It's not really felt to be ethical anymore. Threatening, if you don't read this line, we're going to give you a needle. So, that may work with the residents, but it doesn't work so well with the patients. Or just give them a way out, some way to save face. So currently, I think, what we would all agree on is you have to stress there's a good prognosis. I don't see any evidence of disease. I don't think you're going to go blind. Your eye health looks good to me, things like that. But remember, you have to schedule a follow-up appointment. You have to, if you're going to make a diagnosis of pure functional visual loss, it is incumbent upon you to prove that the patient is eventually 20/20 in a full field bilaterally. Otherwise, your job is not done. So you have to follow them up again, even if you're totally positive it's functional. The current literature recommends not confronting these people, but I don't agree with that because what I talked about last night a lot is that speak the truth in a spirit of love. You got to tell them the truth, and lying to them is really just the same thing as withholding the full truth from them. So you got to let the parents know what's going on. You say, I don't see any evidence, and I say, well, let's look at this. This can't be real, because you can show them the math. You can show them, you can take the child to different distances from the chart, and if they read 20, 200, but yet they read 10, 30. It doesn't add up. You can show that to the parents. You can do a stereo test, and if they see the fly and they see 9 out of 9 circles, and then you blind one eye with a lens or cover it, it all goes away. You can show that to the parents. You say, it doesn't add up. So this is how I know that there's really not anything going on there. And sometimes at that point, the parents will volunteer what the secondary gain motive is or tell you, what's going on. And this is a concept of sadness that really, I hate to say Dr. Ferris invented sadness, but, I will since it's funny. But sadness is an acronym for stress, anxiety, and depression. And what I tell them is, we always have sadness in our life. No matter who we are, just like we talked about last night, there's always sadness in your life somewhere. And I say, where's your sadness? And often you get a quick answer, my grandmother died, or, the girlfriend broke up, something like that. It's a red flag if neither the patient nor the family can identify any areas of stress, anxiety, or depression in their life. Okay, so there's definitely a problem there. But a way to get at this is I'm vulnerable with them and say, I'll tell you how sadness affects me. When I have these things, I get sick at my stomach. That's my weak point. My stomach gets upset when I get sadness. But some people get headaches, and some people get muscle twitches, and some people can't sleep. But there are some people it comes out in their vision. And so you may be one of those people where sadness comes out in your vision. So just like the treatment for my stomach problems is to deal with the sadness, we got to deal with your sadness to help your vision. And that's usually very effective. You say, is there anything physiologic? And it's interestingly, there's been functional MRI research in functional visual loss, and it is abnormal in several areas in the brain, as seen here. So, I guess you could say, well, it is in your head, because in a sense it is. So, antennas up for, in these functional cases, possible abuse, bad parent-child interaction. If the child won't talk to you, the child's uncomfortable around the parent. And when they can't identify any areas of sadness, those are all issues. Sometimes you have to talk to the child alone, and it's always helpful to have a technician or somebody in the room with you to document these conversations and be a witness. But how do we do? So overall, in that study I told you about, overall, the no improvement rate or referral to a psychiatrist for the first time was 11% over a 10-year period. It's up to 50% in the literature. And so although this isn't a statistical study, I would say that that's some evidence that the approach that we use to deal with functional visual loss is rather effective. So, okay, I think that's the end. So I want to thank you for the chance to come back. I've been really enjoyed being with you again. My daughter's had a nice time here. So congratulations to the leadership and to the membership of the Christian Ophthalmology Society for all the great things you have and will accomplish.